Okay, welcome everyone. I'm Amanda Marchung. I'm the Executive Director of the Stanford Center for Innovation and Global Health. Thank you everyone for joining us today for this very timely conversation on global measles outbreaks and trends. The world is seeing an alarming rise in measles cases in many parts of the world, including the US, Europe, and parts of Africa. This rise coincides with the largest sustained drop in the uptake of childhood vaccinations in 30 years, which is being driven by misinformation and post-pandemic vaccine skepticism. This panel conversation also comes at an important moment for measles and other vaccine-related policies in the US, as the CDC's newly reconfigured Vaccine Advisory Committee prepares to convene in the coming days. We have today a powerhouse panel of national and global experts in measles, infectious diseases, and science communications to help us navigate and understand these complex and important issues. It's my pleasure to introduce them to you. So first of all, we have Dr. Peter Hotez. He is Dean of the National School of Tropical Medicine and Professor of Pediatrics and Molecular Virology and Microbiology at Baylor College of Medicine. He is also co-director of the Texas Children's Center for Vaccine Development. Dr. Bonnie Maldonado is Senior Associate Dean for Faculty Development and Engagement. She's a professor of global health and infectious diseases, as well as a professor of the pediatrics and epidemiology and population health here at Stanford. She served as a voting member on the CDC's Advisory Committee on Immunization Practices since last June, until the recent removal of all current members earlier this month. Dr. Esohe Oghboghodo is the Associate Professor in the Department of Public Health and Community Medicine, as well as Chair of the Infection Prevention and Control Committee at the University of Benin Teaching Hospital in Nigeria. She is also one of our fantastic Stanford African Scholars in Global Health. Neha Mukherjee is this year's Stanford-CNN Global Health Media Fellow and has recently led measles coverage for CNN and supported strategic communications for the WHO during the World Health Summit. She's a third-year medical student at Icahn School of Medicine at Mount Sinai. The panel will be moderated by Dr. Michele Berry, who's director of the Stanford Center for Innovation and Global Health, as well as a senior associate dean of global health at Stanford. Just a quick housekeeping note that we've reserved time for audience questions following a short overview presentation and the in-depth panel discussion. So please share your questions using the Q&A feature as they arise. And this webinar is being recorded and will be shared with attendees following the event. So Michele, over to you.
Thank you, Amanda. I am just trying to get this into presentation. As Amanda said, since we have several hundred viewers on this webinar, many of whom have never seen a case of measles, we thought it would be helpful to have a quick review of measles. Measles rubiola is an airborne RNA virus which has no animal reservoir. So it's human-to-human transmission, which really gives us potential to eliminate it or eradicate it. It's a highly contagious highly contagious virus, 90% chance of being infected if you've been exposed, with a basic reproductive number, which means how many people are you going to infect, of 12 to 18 people from one person. And as you can see on the screen, giving you other reproductive numbers for other viruses. The period of contagion is 5 days before and 4 days after the rash appears. The early symptoms of measles are fever, cough, runny nose, conjunctivitis, and the initial rash is really what we call an ananthem, which is within our buccal area near the molars. And you can see in the lower right-hand side, you can see the little white spots. After that starts the skin rash on the outside of our body, or what we call the exanthem, which is a head-to-toe rash, which fades in the same order. The complications of measles are as follows. Quite common, you see a bronchitis with severe coughing. It's a very brassy cough. Pneumonia, which is often a complication which causes death. central nervous system complications, which are both acutely and chronic. An acute encephalitis can occur, but also many months or years after infection, you can see other forms of encephalitis. Disseminated encephalomyelitis, subacute sclerosing panencephalitis, and measles inclusion body encephalitis. Death is really usually a respiratory or secondary bacterial infection death, and one can be left with blindness and hearing loss. If you're pregnant, you can have spontaneous abortion, intrauterine fetal death, low birth weight, and even maternal death. The diagnosis of measles is really a clinical diagnosis, which is why I wanted to go over some of the signs and symptoms. Um, you can get laboratory confirmation with a PCR of throat, nasopharyngeal swab, or urine a few days before the rash to several days afterwards. And then you can also get a serology, a measles IgM, but it's only sensitive days 3 to 30 after a rash. Prevention of measles, we've all heard about the MMR vaccine. 2 doses gives you a 93% efficacy. I'm sorry, 1 dose gives you 93, and 2 doses about 97% protection. It is, unfortunately, a live attenuated vaccine, so it's contraindicated in pregnancy or with any patient that has severe immunosuppression. Post-exposure prophylaxis, if you've been exposed and you're not up to date with vaccine, is really an MMR vaccine within 72 hours or immune globulin with 6 days for high-risk contacts or immunosuppressed contacts. The reported cases of measles worldwide, as you know, we have about over 1,000 cases right now in the United States. But I thought it'd be interesting to just look at some of the global numbers, which you can see Yemen really has the most cases right now of over 10,000. But you can see that many other countries have quite significant cases of measles. And you're going to be hearing from one of our Nigerian colleagues where there's about 2,500 cases of measles currently reported. So I am now going to, if we can stop the slides and go to a full screen of our panelists. I guess I have to stop sharing. Let's see. Well, we can talk until I figure out how to stop sharing. But basically, I'm going to start with Peter. Peter, you're from Texas, where it's really the epicenter of this new outbreak. What countermeasures do you see being put into place, and why is it so hard to contain this outbreak?
Yeah, well, thanks, Michelle, and thanks for having me. This epidemic in West Texas has been going on since the middle of January. So we're going probably soon into our 7th month of this epidemic. And the reason that's significant is the Centers for Disease Control itself set the criteria that if you will lose your elimination status if you have ongoing transmission for 12 months or more. So hopefully we won't get there, but we're coming awfully close. So this epidemic began in West Texas, then accelerated up into the panhandle of Texas and really across the Great Plains area of the U.S. It spilled over into the adjoining area of New Mexico and up into Oklahoma and Kansas. And what's interesting is when you look at the geography of that epidemic, which now has roughly around 1,000 cases and 100 hospitalizations and 2 deaths among otherwise well school-age kids whose parents decided not to vaccinate them, is the place where it's happening is overlaps pretty tightly with where we had the lowest COVID vaccination rates in the country, those same areas. So to me, the message is it's a spillover of anti-vaccine activism that accelerated during the pandemic, now spilling back over to childhood immunizations, which is something that we feared and unfortunately seems to be happening. So, the question then is how do you walk it back? And for because one of the big concerns that I'm seeing is there's no feedback loop, there's no auto correction. In the past, when there's a big measles epidemic in a community, kids go into the hospital, some in the intensive care unit, and parents say, "Oh my God, what's going on here?" And there's catch-up immunizations, and that's the end of it. But now we have two instances where that feedback's not happening. So, with the COVID pandemic, of the Texas was probably the worst affected state, tied with California, but of course Texas has a much smaller population, so arguably Texas the worst affected state. 100,000 Texans died. Almost half died after vaccines became widely available because so many Texans refused to take a COVID vaccine. There was no feedback loop. There was no, if anything, the anti-vaccine activists doubled down and they tried to blame vaccines for the deaths and this sort of nonsense. And it's the same thing with measles. You're not seeing that feedback where I mean, there is some catch-up immunization. I think our public health authorities in Texas have been doing a good job, but things seem really dug in, more than I've ever seen it before in these rural conservative areas of the Great Plains of the United States. So that's kind of my 30,000-foot aerial view of
Mhm.
things.
There was a very poignant story in the New York Times yesterday about a rural chiropractor in North Dakota caring in the midst of this outbreak for a population with no access to doctors. Since we have many healthcare workers on this line, if you are an adult or a healthcare worker in the midst of an outbreak, what measures can you put in place to protect yourself or others? Um, for instance, should you re-immunize yourself? Should you test for immunity? What should healthcare workers do?
Well, I actually I was invited to write a brief article just on that topic. Even though I'm a pediatrician, the Annals of Internal Medicine made an exception and let me publish there. It's a great journal, and to really look at it, and it has relevance because this may become the new normal for the U.S. So, vaccinating in our current epidemic in Texas and the adjoining states could be what we're going to have to do routinely in the U.S. And among the recommendations, well, first of all, they break it down by age, so that if you were born in the late 1980s and you can document that you got 2 doses of MMR vaccine, measles, mumps, rubella vaccine, there appears to be no basis for a third dose. So that's useful information. What's interesting, though, if you look at the opposite extreme, it be born before 1957, if you go to the Centers for Disease Control website or other sources of information, the typical line is that, well, there was so much measles virus transmission back then, chances are you had natural infection with measles, and therefore there should be nothing to do. But there's an asterisk, and the asterisk is if you are a healthcare provider and having a lot of exposure, the recommendation is to go ahead with that um, two immunization series. So that may become potentially could become a more generalized recommendation. And similarly, if you're born between 1957 and 1989, and you can document that you got a single dose, their recommendation is during an outbreak setting is to go ahead and get that second dose. So in a 10 county area in Texas, that's what the Texas Department of State Health Services is recommending. But it occurred to me, if now measles transmission becomes new normal here, that could become a potentially a more generalized recommendation. So that was what
So, Peter, the only
the
thing I'd want
article.
to add there is that there are probably not very many providers who were born before 1957 at this point. So that's the only good news there is that that you're talking about people who are probably in their 70s at this point. So
Well, I'm getting close. I was born in
yeah, but
1958,
do you
so
take
I'm
care
a
of
year
patients?
late.
No, it was very sad that this particular doctor did get infected with measles. So I wanted to bring out what
Right.
when healthcare workers. Bonnie, do you have
Yeah.
something to add on that
Yeah,
area?
let me talk about that because I took care of a lot of these patients when I was a junior faculty member. I've seen a lot of measles cases. I'm sure Peter, you have as well, and Michele, and I'm sure Dr. Oghboghodo has as well. One of the things we need to remember when you think about the way you decide how to vaccinate and who to vaccinate, remember this is a disease that's very interesting. And that's one of the very few diseases for which we are pretty sure with almost 100% certainty, and you're rarely sure 100% of anything, that you have lifelong immunity. That means that you will very unlikely ever get infected if you've ever been vaccinated or with an appropriate dose of vaccine, with I'll give you the caveats, or if you've had actual wild type infection. So it's lifelong immunity, which is very rare. You don't see that with very many diseases. The other interesting thing about the virus is it creates sterilizing immunity, and so does the vaccine, which is very unusual. So for most diseases, you can get immunized, so you're protected yourself, but you will no longer become infected and infect others. And that's not true for most diseases. So if you have a measles vaccine or measles infection, you can be exposed and you will not become infected. There won't, measles viremia will not happen. You will not, the virus will not circulate in your body, and you cannot be infectious to others. So it really does shut down the chain of transmission. And honestly, we could have really eradicated measles already
Yep.
many, many years ago, because it's much easier to eradicate than polio is, which we're almost at the brink of eradicating, but we would have eliminated measles before. But the other point is the vaccine, actually, one dose of vaccine actually provides full immunity to about 93% of people. There's probably genetic reasons for why 7%, 5 to 7% of people don't respond. So one dose actually provides about 93% of the population with full lifelong sterilizing immunity. That's incredible. Now, the reason we instituted a second dose is because in the 1980s, there was a big outbreak of measles in the US, and that led people to doubt whether the vaccine was working. They call that primary actually, they call that secondary vaccine failure. So people thought, well, this means that the vaccine fades over time. And that actually turned out not to be true. It turned out that what happened was inner city kids were not getting vaccinated and so there was actually a failure to vaccinate rather than a vaccine failure. And so because it's so infectious, 7% of the population getting one. So first of all, some people weren't getting vaccinated. And secondly, once you have measles spreading in a community, 7% of the people who got one dose turns out to be a lot of people if you're talking about a huge cohort. So 7% of a million people is still 70,000 people, and that's a lot of people to be susceptible. So the vaccine in the late 80s was recommended then to be given in a 2-dose formulation in the US, and then WHO subsequently took that up as well, because that second dose actually may or may not do much for that person who responded to the first dose, but it narrows the window of the people who didn't respond to the first dose down to about 3% of people. So that's why that second dose is so important.
Thank you. So, Peter, I'm going to just turn to you for one other question. You've been involved with Gavi and WHO, and I'm curious as to what, if you can, and actually this is a question from our audience already, could you comment on the impact of reductions in U.S. foreign aid and technical assistance for disease surveillance, and how that will impact measles control globally? And if you
Well,
could sort of comment on the global trends that you're seeing.
well, there's a lot of moving parts to this. So for even though you didn't ask about it, one of the things that I'm watching also is the spillover of US style anti-vaccine activism around health freedom and the wellness influencer industry now globalizing. And you're starting to see some of the same videos and memes and everything else now that we see in the US on the African continent, even in Latin America. You know, Texas Children's Hospital has relationships with a number of Latin American pediatric societies, the Colombian and Mexican and Brazil. And, you know, when I would go down there on behalf of Texas Children's, the first thing I would do is congratulate the pediatricians for kind of holding the line and preventing Latin America from becoming contaminated with US style anti-vaccine activism. Anecdotally, there's not data to support it that I've seen, but anecdotally, that seems to be faltering now. It seems that we're starting to see this kind of erosion of big support, not from the pediatricians, they're still very supportive, but the anti-vaccine sentiment seems to be now getting exported. So that's problem number one. And then problem two, of course, is the US pullout of support for the Gavi Alliance and the World Health Organization. And in terms of Gavi, I can't think of a more successful public health organization. I mean, you look at the numbers from the Institute for Health Metrics and Evaluation, and in terms of under 5 childhood deaths since the start of the Gavi Alliance from 2000 to the latest numbers that they have from 2021, we're looking at more than a 90% reduction in under 5 childhood deaths from measles and pertussis and the others. And I can't imagine a better success story to tell. And I have to believe with that substantial reduction of support that there will be effects, and it's going to be really challenging for the leadership to maintain that high level of efficiency and quality control. So
So can I add to that, Peter, that post-COVID, the Gates Foundation did a really nice job with their goalkeepers report. And what they predicted in 2020 was that we would see a 14 to 15% drop in overall vaccination in the world because of COVID impact. And fortunately, because of the efforts at the global level, the overall vaccination drop for childhood vaccines was not 14%. It still dropped, but it dropped to about 7% below normal rates. Currently, the vaccination rates around the world for measles are this is from last year's data, about 83%, and a second dose is at about 70% or so. And so we're still seeing a fairly good number, but it's really dropping off and obviously well below the higher level threshold of
yeah,
about.
I mean, I think, what's happening
Yeah.
is you're right. I think it was, the social disruptions from COVID and
Well,
potentially
I want to
diversion of
ask Esohe.
resources, but now I think superimposed on that, I'm worried about, this export of anti-vaccine activism.
I want to follow up, Peter, on your statement about the spillover to other countries. And since we have one of our panelists is from Nigeria, I'd like to ask her, literally, what role does this anti-vax spillover happen? How is it impacting Nigeria?
Oh, yes, it is impacting Nigeria significantly. We have our own anti-vaxxers here. Data shows that in 2022, our MCV vaccination rate was 63% nationally, but it has fallen to below 50% nationally now. And like he said, like Peter said, and like Bonnie said, all these we are seeing all these post-COVID. And so with the rise of the anti-vaxxers, the hesitancy, the vaccine hesitancy, we are seeing a significant drop in vaccine uptake. And it is not just for measles. Right now in Edo State and in Nigeria, we are having a diphtheria outbreak. And so we are seeing these patterns, not just for only measles, but for all the other vaccine preventable diseases.
So thank you, Esohe. I'm going to turn over to Neha, who's been doing CNN reporting on misinformation and how pediatricians can actually speak to vaccine hesitant families. Neha, do you want to give us those key lessons that you've learned from the CNN reporting?
Sure. Thank you, Dr. Berry. I think that question is especially important because I was chatting with Catherine Wells, who's the director of Lubbock Public Health in the heart of the Texas outbreak, and she said what she thinks has led to some increased vaccination in some areas are those conversations with pediatricians. She thinks that's been the most effective way. So I think some of the key tips I got from speaking with pediatricians across the country were, one, to treat the parents that they're talking to like partners, not talk down to them, speak with a lot of compassion, really understand where they're coming from. Two is, to understand what are their specific concerns about the vaccine, because we use vaccine hesitancy very broadly, but it actually means a lot of different things. Some people are worried about an ingredient they heard about, and some people are worried about an adverse effect they heard about. So I think, doctors need to get to what is it that is concerning people and address that, very specifically. Third, a lot of the pediatricians I talked to said that when they tell their patients that their vaccine decisions also impact the whole community, that really helps too, understanding it's not just the person who's getting the vaccine, but those around them in their immediate community and even farther away. And lastly, I think, not to scare patients or patient families, but to stress how serious measles can be, measles or other vaccine preventable illnesses. Like we talked about earlier, 100 kids are in the hospital and tragically two have died from something that is preventable. So when physicians have, spoken to families about how severe it can be, I think that's also been really effective in trying to get more families vaccinated.
Thank you. I mean, as long as you brought up some of the concerns that patients have, I'm going to throw this out to the panelists as well. There was a very poignant piece in the New York Times this morning, an opinion piece of I caused autism. I caused autism in the United States by actually redefining what the characteristics of DSM diagnosis for autism is. I'd love for one of the panelists to talk about the measles autism link and also the vitamin A. Bonnie, you want to take that? What is the role of vitamin A?
Well, yeah,
and
so
there's a question actually in our chat is what about mercury and some of the other components of the measles vaccine that one might be worried about?
yeah, so I'm going to try to, and Peter, back me up here. It's been a long time, but there's the story about mercury is a very long and very complicated one, and I feel like it was purposely made complicated to obfuscate the real issue. But the point is that there is no mercury in any vaccines. There was methyl and ethyl mercury. Now, the component that is in the vaccine is an inert component that used to be in vaccines many years ago, in the 90s actually, and that was used as a sterilizing agent. At that time, the ACIP, the Advisory Committee on Immunization Practices of the Centers for Disease Control and Prevention, actually convened and decided that they would take that component out because people were confusing it with the active mercury component, the methyl mercury component. And so there has never been an active mercury component in vaccines, but the inactive form of ethyl mercury was a stabilizer and back in the 90s. There's no, it's called thimerosal. And thimerosal has not been in vaccines except for one vaccine now. And it is the multi-dose influenza vaccine product that very few people use today. That particular vaccine still has thimerosal in it. The rest do not. No other vaccine, and no vaccines for kids have thimerosal in them except for the multi-dose flu component vaccine, and none for pregnant women either. And so the issue around mercury is that there was a paper written in the 90s by a British gastroenterologist named Andrew Wakefield, and he stated that he had looked at cases, a dozen or so cases of children who had autism or other neurodevelopmental disorders, and also had found measles virus in their gastrointestinal tract, in biopsies of their gastrointestinal tract. Well, ultimately, it was found that he actually fabricated the data. Nobody was able to reproduce it. It took many, many years, but that was found to be fabricated data, and that he was also working for another company that was producing measles, a different type of measles vaccine that he was being paid by that company at the time that he wrote that paper in Lancet. That paper was discredited. It was taken down. His license was actually taken away in England. And then he came to the United States and started working very, very vehemently and continues to work. And Peter can speak more about that around the anti-vaccine movement. And there continues to be conspiracies around autism and measles because of that finding. Now, numerous studies, I would say, hundreds of studies involving, I would say, millions of children all around the world using retrospective and prospective studies, data sets from all countries all around the world, continents, almost every continent, looking at the relationship or lack of a relationship between autism and measles vaccination, and no relationship has been found. And Peter's actually written a book about this, so he can talk more to it. But there's no data to support that autism is found in vaccines. Yet today you can talk to anybody in the street, and the first thing they'll ask you about measles is it true that measles causes autism? It's amazing. One paper in the 90s that was discredited has really wreaked all of this havoc.
And yet we have HHS really funding new studies to look at this link, which brings me to HHS.
Well, let me just say,
so Peter should say something, because he's the expert here.
Absolutely.
Just because, I have a daughter with autism and intellectual disabilities, and was asked to talk to Mr. Kennedy back in 2017 for a year, and that's what led to my writing the book. Vaccines did not cause Rachel's autism. It's as Dr. Maldonado points out, it's a series of whatever metaphor you want to use, whack-a-mole or moving goalposts. The anti-vaccine groups make an assertion, the scientific community debunks it, then they switch it around to something else. So the original assertion from the Wakefield paper in 1998 was the MMR vaccine. That was shown to be, that paper was retracted and followed by large cohort studies showing kids who got the MMR vaccine were no more likely to acquire autism than kids who didn't. That should have been the end of it. But then Mr. Kennedy, Robert F. Kennedy Jr. in 2005, wrote an article in Rolling Stone magazine, simultaneously published in Salon magazine, claiming, okay, if it's not MMR, it must be thimerosal preservative that used to be in vaccines. Similarly, debunked large cohort studies, even non-human primate studies. Then it was switched up again to spacing vaccines that were overwhelming the immune system. And you had these celebrities parading around in green t-shirts saying you have to green our vaccine ecosystem. It was all BS. It was all made up. And then it's alum in vaccines. And each time the scientific community does an excellent job of showing it's not the case, but it does become this exhausting exercise. But I think the other piece that's really important to point out, Michele, is it's not just the study showing there's no link, it's the lack of plausibility, because we've learned so much about autism and how it begins in early fetal brain development through the action of autism genes. And so far, 100 autism genes have been described, all involved in early fetal brain development, well before kids ever see vaccines. In fact, one of the best autism researchers, in my view, is at Stanford, Sergio Pasca, in neuroscience, has done these extraordinary studies with brain assembloids and organoids using neurons with autism genes showing aberrant migratory patterns. So it's a complete story. It doesn't mean that there's no environmental impact, but if it's an environmental exposure, it's early on in pregnancy. So for instance, if you're pregnant and not aware of it and on an anti-seizure medication called Depakote or valproic acid, your child, that interacts with autism genes, and there's a higher likelihood your child could be born with an autism phenotype. And in the book, and talking to Mr. Kennedy, there's about half a dozen chemical exposures that we know about. There's probably many others, but all in early pregnancy. And that was the real frustrating part of talking to him. Was I said, Bobby, you're an environmental attorney. This is your moment. This is your sweet spot. You should be all over this. And he had zero interest. And so that was frustrating. He had this sort of fixed belief about vaccines, despite the massive evidence showing no link, but again, the lack of plausibility. And I think that's the really important point.
Thank you. I want to bring it back to the global, since this is also Measles Without Borders, and I want to go back to Esohe, because you have a wonderful large country. I think Nigeria has like 200 million people. How many millions? But yet you have an area that's really very inaccessible, that's in conflict, hard to get into. How do you actually work with that situation in your country to get coverage? Because you need a certain amount of coverage to have herd immunity. I think you muted, Esohe. You muted. You have to unmute you. We still can't hear you. Can you? Yes.
Oh,
Well,
you
still,
just remuted yourself again.
you muted again. Okay.
Okay. So, yes, you're very right. Right now, in the northern parts of Nigeria, we are having a lot of security issues. And for now, the statistics show that we have about 6 confirmed cases of measles, and in 34 states of the country out of 36, and the FCT. And many of the measles outbreak now is located in the northern part of the country. More than 80% of the measles cases we are seeing is located in the northern part of the country, where we are having a lot of security issues. But what we are trying to do now is that we are having data-driven outbreak response planning, and we are leveraging mobile outreaches and task shifting models. We are also using integrated campaigns to ensure that we get to the hard to reach areas, trying as much as possible to balance routine and outbreak immunization to ensure that all the children that can be reached are reached.
It's difficult. That last mile is always difficult. It's more than 1 mile that you're trying to breach.
Yes, it is.
Can I just mention something about, thank you for that really wonderful overview about outreach. But one of the areas that I've worked in for over 30 years now is in polio eradication. And we can really take a lesson. And again, just so you all know, in the 1990s, 1 million children a year died from measles. 1 million a year died from measles. Last year, about 107,000 children died from measles. Now, that's still 107,000 too many children. That's a 90% decrease. And that's solely because of vaccination. Now, what we could have done if we had focused on measles first and not polio, measles would be gone. The secret here, as you've heard, is very high level systemic work to get vaccines out to every last child. And measles, polio attracted billions of dollars in funding to get to every child. And I don't have time to talk about the epidemiology, but it's very different from measles. You need more resources to eradicate polio. And we're on the brink of eliminating polio from the face of the earth if we continue to vaccinate. But we could have done this with measles, and it really does take extensive work to get to all these kids. And the interesting thing about polio, it's much harder. So with measles, if you could even just get 1 dose to most of these kids, I mean, obviously you want 2, we would really have substantially reduced the number, the chances that we would have any measles outbreaks in the world at this point. So these efforts are really, really important, and they do involve getting to small villages and towns all over the countryside, because again, this is such a contagious disease that it just spreads like wildfire, and it takes the efforts. When I worked with the World Health Organization on the polio campaigns, we would hear from countries in different parts of the world that had, even with Gavi help and other help, still their vaccination rates were sometimes in the single digits because of the lack of infrastructure at the local level to get vaccines out, just even basic vaccines out to kids.
I do want to get, thanks, Bonnie, for
Yes.
that.
So just to add to
Go for it. Go at Esohe.
Oh, okay. Thank you. So just to add to what Bonnie said concerning the WHO, I know that we have also adopted what the WHO's tailoring immunization programs as the WHO TIP approach. And that approach, actually, we use it for high burden states. For example, in Kano and Katsina now, 2 states up north, those are we are using the WHO TIP approach. And what that does is that we help to look at a segment of the highly hesitant population and tailor the interventions to meet the needs of that population. And so, like Neha said when she was speaking, what exactly are the parents hesitant about? And if we're able to look, identify, itemize the things that the parents are hesitant about, then we can speak to those things and improve vaccination uptake and vaccination coverage.
Thank you. I'd like to, before we open it up to the audience, turn back to our student and the CNN coverage that she's been doing. What have been some of the challenges, Neha, that you've had actually in reporting this outbreak? And what lessons have you learned from public health communication?
Well, I think it's certainly been a challenge to report on the outbreak, just in terms of how long it's been going on and how in-depth we need the coverage to be to reach a variety of people. I think specifically what gets challenging is that the most impactful coverage is local, talking to local experts, talking to the people who are really affected. At the same time, these aren't just numbers of cases that are rising and numbers of people that are in the hospital. They're real people who are sick, real people who are having to bring their children to the hospital. So I think, a lot of the challenge is balancing that need for information with also a respect for privacy and also a respect for real people who are struggling with this. Most of them, I think all for the first time. We haven't, in many years seen a measles outbreak in that specific area. So I think, it's recognizing that this is a challenge for everybody is something that we definitely came across. And then I think for public communications as a whole, what I've really learned is the importance of clarity. And we talked about this a little bit before, but science is ever evolving. There's a lot of things we don't know, but I think being transparent about those things that we don't know really can help to build trust. So I think that adds to our ability to be clear if we just are more transparent about the things that we're researching, the things that we're looking into. And in that same vein, I think it's important to be clear about the actual science that we're talking about. Sometimes we get a little bit bogged down in so much jargon, but if we as science communicators can really do our job to understand the issues in depth, we can also take a step back and try to explain them really accessibly and really, more easily so that it can be, easily readable by a wide audience. So I think just clarity would be my take home lesson from my time with CNN.
And as we go forward, Bonnie, I'll add one other question because you were dismissed from the ACIP committee along with 16 other members.
We were fired.
Yes. And so I guess my question to you is, what are the potential consequences of this new committee? What should we expect? They're meeting, I think, June 25th. What should we expect to come out of this committee? I know you've written about this, so.
Yeah, so I was for a year a member of the Advisory Committee on Immunization Practices. It's the Vaccine Advisory Committee to the CDC. It is a congressionally mandated committee, so it can't be completely taken down by anybody except by Congress, which is why it's still, I believe, it still exists because it can't be taken down by executive order. It's a congressionally mandated committee, and there aren't very many of them. And it's also mandated by the 20th Century Cures Act, again, a congressional mandate, that any vaccine that is approved by the Food and Drug Administration within 60 days needs to be reviewed by the ACIP. So we are mandated to review every vaccine. Now, what's important to know is that this committee members, I don't know, some of us were terminated on June 9th, a couple Mondays ago, we found out about it in the Wall Street Journal by reading an op-ed by the secretary of HHS. And then several hours later, we got a very short notice saying we'd been terminated immediately. 2 days later, so our process, and you can read the op-ed if you're interested. We wrote an op-ed in JAMA about what we think about ACIP and the responsibility that ICIP members should have. It took most of us about a year to 2 years to get appointed to be members. We had a thorough vetting process, and in some cases, people had applied several times before they were appointed. The people who took our place were 8 appointees that were appointed 2 days after we were let go. So we don't know anything about how they were picked, what the process was to appoint them, what they had to divulge, and subsequently a number of them have had conflicts, major conflicts. That is, being involved in lawsuits with companies around vaccines, none of which any of us had. And our conflicts were said to be, severe conflicts of interest. And what most of us were doing were actually involved with vaccine trials that were completely transparent and open to the public to review before we actually got on the committee. So what do I think is going to happen? I have no idea what will happen. This is a group of 8 people who most of us in the field, and Peter, you probably know most of them. I do as well. You can look at their record. I am not going to speak for them or say what they're going to do, because I want them to be open and transparent about listening to the views of science and data as they go through and review the vaccines that will be brought up at the meeting on this Wednesday and Thursday. Now, at the very minimum, it takes most of us on the committee months, if not years, to be experts in the vaccines that we review for the ACIP. The ACIP meets and talks about vaccines that have been on their dockets in work groups for months and years. So we're going through the disease prevalence, the epidemiology, the vaccine products, all of the different aspects of these diseases and the vaccine products that may be coming forward. So the meeting itself is a culmination of hundreds of hours of work. And we were, again, summarily dismissed 2 weeks ago. These people have had maybe a week or 2 weeks to get up to speed. Half of the vaccines on the docket for the agenda were taken down because they're not going to have the time to really review the materials. We don't know what they're going to talk about. We don't know the presenters. Not very clear who's presenting a lot of the information about these products. And the other piece of information is that they're going to have to take votes on really important vaccines at the very minimum for the fall respiratory season, so flu and RSV. So at the very minimum, there will be a disruption in their ability to really have time to review data so they can understand it and discuss it. The final thing I will say is, as far as I know, as of today, the 31 non-voting liaisons, which includes AAP, ACOG, AAFP, all of the others, have not been invited to the meeting. And they may be invited. Maybe it's still Monday, and the meeting is on Wednesday. But generally, they have a seat at the table. They don't vote, but they get a chance to speak directly and are able to talk at the meeting itself and make comments. So far, none of them have actually been invited to this meeting. So in terms of transparency and understanding data and facts that drive vaccine science, it's not very clear what might happen, but I'm still hoping that they will listen to the patterns that ACIP members have put in to place to try to build confidence. And I will also say one last thing, that we receive lots and lots of emails from the public, from medical professionals, from media, as ACIP members. And those comments have been incredibly positive and supportive. So we have not heard people saying, take away our vaccines. In fact, more and more people are saying we want vaccines to be available Now, it's a very skewed population, obviously, but we are hearing more and more from people that they want the ability to choose and have vaccines available to them.
Thank you. I'm going to open it up to some of the questions that are coming live from the audience. I'm going to combine a few of them because there are many. One question is basically that there's been very extensive conversations and discussions by health professionals, and yet these are very wordy and academic, whereas the anti-vaccine message is very simple and united. And what will it take for health professionals to get on the same page? This particular questionnaire, I'm going to combine it with another question, really, and I was actually going to talk about this, but didn't get to it, is that many children don't necessarily die from measles. They actually die from the secondary infections that they get from measles. And there's something called measles-induced immune amnesia, which causes these secondary bacterial infections. Can one of the, any of the pediatricians comment upon that?
Yeah, so that's a little bit of a mixed bag. So basically, what children die of when they die, so when children die from measles, they die from basically pneumonia or diarrheal disease. That's number one. The measles-induced amnesia is something that actually happens over a longer period of time. And what happens is the measles vaccine, the measles virus, the wild-type measles, induces a destruction of memory B cells and actually probably T cells as well. So that when you look at them over the period of 2 to 3 years after measles disease, they have a depleted pool of B and T cells, and these are memory cells that they have an abundance of naive B and T cells, which means that they're growing new immune cells, but their memory of existing immunity has been depleted. And as far as I know, and Peter, maybe you know better, but this seems to be at least a 2 to 3 to 4 year phenomenon. So apparently some of these cells do start coming back over time, but it's hard to know if those are just newer naive cells that have been primed to new antigens. But there's definitely that longer term immune deficit, but the short term is that these children die from normal childhood diseases, but they are unable to fight them. So they die of measles pneumonia, they die from diarrheal disease, and they can die from measles induced bacterial secondary infection.
Yeah, that's right. It's a good summary. I would say the secondary pneumonias, from strep or staphylococcal pneumonias that you can see as secondary, but the overwhelming reason for the high morbidity and mortality that the 100 kids are hospitalized in Texas is a direct effect of the virus. It causes what's called a giant cell pneumonia, also neurologic injury, including deafness, which is often a permanent, measles encephalitis, measles diarrheal illness. And then, yes, you can see secondary bacterial infections, but generally the big impact is direct virus infection. In terms of how to communicate, relative to the anti-vaccine activists, it's tough. Let me give you an example. Last year we had our friend, the Florida Surgeon General, Dr. Ladapo, come out and say that mRNA vaccines are causing turbo cancers because the mRNA genome or contaminating DNA is inserting into our genome and activating oncogenes. And so, you go up there and you say, well, first of all, there's no such thing as a turbo cancer. That's a totally made up term. They just made it up. There is no such thing as a turbo cancer. Second, the nucleic acid introduced by the mRNA through lipid nanoparticle gets past the cell membrane into the cytoplasm, but it doesn't get in through the nuclear membrane into the nucleus. For that, you need electroporation, and that's why we don't have a licensed DNA vaccines. And even if some residual did, we have proteins of our innate immune system that will block integration of foreign nucleic acid into our genome. Otherwise, every time we ate a hamburger, we'd have cow DNA into our genome, and that doesn't happen. And then people get it. Now, the problem is this. I mean, I can talk about this till I'm blue in the face going on CNN and MSNBC, but the people we need to reach are not watching CNN and MSNBC. They're watching Fox News and Joe Rogan podcasts and Tucker Carlson and far-right conspiracy sites. And this is, I think, to me, the essential problem. I mean, I'm sure Neha has some experience with this as well, that they're they're sort of walled off. And, I was going on Fox News in the beginning of the pandemic, and then when I refused to go along with the hydroxychloroquine nonsense, the invitation stopped. So how do we reach the people we need to reach? I think this has become a really, really important question.
Neha, any ideas of how we reach those people?
Yeah, I mean, I think the other piece of that is that even on social media, the algorithms make it such that we see content that we're going to agree with because that's what people want to see. So I think it becomes an even bigger problem to try to reach people on social media where things are already shorter and already not the whole story. If you just continue to see conversation that's, within that loop of information you're already seeing. So I think the best thing that we can do, and what I've heard from people I've spoken to, is the individual conversations with providers can go a long way because those are person to person. It's not so politicized, it's not on a news channel necessarily. I think that those discussions can really do a lot to break stigma and break some barriers.
I'm going to end. Thank you.
Okay.
I'm going to end with, oh, go ahead, Esohe.
Oh, okay. So for me, I think that we need to take some lessons from the anti-vaxxers in terms of wording their messages and framing their messages and use it to our advantage. For example, their messages are quite simple and they are one-liners, they are emotionally charged, they use coordinated networks too, and they always use distrust as a tool. Distrust for the government, distrust for the healthcare workers, distrust for the vaccines itself. And so we need to simplify our science without losing accuracy when we are bringing out our messages. Also, we need to use empathy and storytelling as tools as healthcare workers in bringing out the message for vaccines, in ensuring that parents take those vaccines for their children. We need to master the medium. We need to be sure use good visuals that hit the nail on the head, as it were. And then we need to start pre-bunking and not necessarily debunking all the time, because every time we are at the disadvantage, the news is out and then we are debunking the news. Sometimes we need to start anticipating what kind of news can come out and pre-bunk. I think that we need to, as healthcare workers, as healthcare professionals in the field, especially as persons who wish for our vaccine preventable diseases to be greatly reduced. I think that we need to start looking at this. Thank you.
Thank you so much, Esohe. Unfortunately, we've reached the end of our time. So I want to thank our panelists as well as our moderator for this really informative conversation that has shed light on global themes, challenges, and solutions to address the growing measles crisis. Thank you to all who joined and asked insightful questions. We really value your feedback and we want to know how to improve future webinars. So please take a minute to fill out the evaluation form that you will receive as soon as this webinar ends. And I encourage you to sign up for our newsletter and stay informed about upcoming events by visiting globalhealth.stanford.edu. So thank you so much for tuning in and have a wonderful day or evening.